Well, it is wonderful to be here, and as I talk a little bit about CAUTIs, I was thinking of problem solving, and I think Michelle is maybe my new best friend because we actually had a conversation at least 10 times yesterday. But in terms of problem solving, I was really proud of myself because we had some conversations, and there was weather coming here, but Rochester looked pretty good. Little did I know that there had been cancellations from the day before. So everything was backed up. It's winter break. The flights are oversold to begin with. My flight is delayed. The connection is delayed. I would not get into Kansas City, and I'm trying to figure it. So I go up to the counter, I'm in line, and this gentleman goes up. We can't get out. There's no way we can get out today, et cetera, et cetera. So I think, oh my gosh. So I'm looking at other airlines. I said, did you check the other airlines? Oh yeah, they're all sold out. So I leave the counter and I start trolling the counters. I'm going up to Delta, and I'm going up here, and I'm going up there. I'm trying to figure nobody can help me out. So then I think, okay. Then go back to the counter and get another gentleman. And I said, well, how about Buffalo? It's like an hour and 15 minutes away, and luckily they got me out through Buffalo. So the moral of the story has nothing to do with CAUTIs, but the idea is sometimes when we think about things, we think that we can't do that. You know, here's the answer, and we don't pursue it a little further. So that's why I kind of point that out. So I did get here late last night, but I'm very excited to be here. And I'm really excited that there are a number of infection preventionists as well as leaders here. And my first question, though, I didn't kind of get a sense, how many people here are frontline staff that actually work the units? Do we have frontline staff? Great, because you guys are the nuts and bolts of what makes this happen. And it really and truly is, and that's what it's all about. And I've been doing infection prevention for a number of years now. And it's just recently that I realized that I don't own it. What I am, I'll make an analogy to like football. We're like the coaches, and they really do need us because you can't have a big team without a good coach. But by the same token, for years and years, everybody thought infection prevention or quality or utilization review owned it, and we really don't. So our job really, for most of us, is to inspire others, to kind of get them on the right page, to use the technical expertise that we do have, and really inspire the frontline team to do that. So today we're going to talk a little bit about what is really the most difficult thing, and that's sustainability. And why I mentioned it's a marathon, not a sprint. But in my own organization, I don't know how many of you are like this, but in my own organization, we are doers, we are movers, we are goers. So what happens? We have a new project, we are on. We are 100%. We are the first person to finish. When the skin measures came out, we were part of the premier demo project, and we were always winning awards because best antibiotic appropriateness, the best timing, all of those things. Over time, what happens to some of us sprinters? We kind of die down, we get tired, and we don't sustain it. Interestingly enough, when Michelle mentioned the award we got from non-ICU bloodstream infections, we were about one of the first hospitals that really started looking at bloodstream infections outside the ICU, and we won an award, we published a paper. And a few years later, we looked back and we said, we kind of lost that game. So talking about sustainability is a huge issue and something we really need to think about. So one of the things, just to review cost behavior, and I think what's different about this, because one of the things I think you probably are all getting exhausted with, oh, okay, thank you so much, it wasn't on. One of the things I get tired of, and I saw in your slides earlier, is this idea of multiple priorities. You know, first we have this, and then we have partnership for patients, and we have CMS reporting, and if you're in infection prevention, there's a new NHSN thing you have to report, and all of this just becomes mind-boggling. But the bottom line about this CAUTI initiative is it truly is different. And I have to tell you, as an infection preventionist, I am a technical expert, but the one lesson I have learned from my CAUTI work and on my coaching calls is that there is and through this, but there's a technical and socio-adaptive side. The technical alone will not get you to where you need to be. And in the infection prevention literature, we call it implementation science. So we know what to do, the evidence is there, but how do we get people? How do we hardwire it into our daily practices? And that becomes very, very difficult. So just to kind of review a little bit, it's really behavioral based, and there's engagement and there's execution. A lot of what we do in this world is we don't engage first, and I'll talk a little bit about that later on. But really, oftentimes, we send people to lectures, we say, you have to learn this. We don't tell them why it's important, we don't get them on board, we don't get them engaged. So all of these things are very, very important. So really, CUSP is kind of that umbrella that envelopes all this. Well, here's my organization, and here is one of our CUSP teams that is focusing on infection prevention. And we have a number of CUSP teams, so it's not just a CAUTI team, but we have decided on this busy surgical unit that we're going to focus on infection prevention. I happen to be the coach for this team, and it's just kind of a coincidence. The coaches that we choose for the teams are just people who are engaged, who aren't necessarily working on that team, who can be objective. The little gal here, Tiffany, is the frontline, the nurse champion. What I can tell you is when you have your CAUTI teams, and I know you're past that, but as you begin to spread, this is one of the most important roles. So really think very, very carefully as we move into spread who you're going to have for that champion on your team. The other person next to me over there on the other side is the nurse manager on that unit. And I heard a lot of you say that you were leaders or managers. That is, in my mind, the most important position you can have. The frontline manager is really the person who's going to make or break quality on a unit, on a specific unit. So that frontline manager. Next to her, just coincidentally, is our senior leader. And one of the things I've heard about on some of my coaching calls is that leadership engagement sometimes is lacking. And when I talk about leadership engagement, it's attaboy, Linda, go fix it. Or it's, yeah, we support quality. But true engagement by leadership is really something that is required and necessary skill. This happens to be our CNO. She and I make rounds at least once a month on the CUSP unit. We talk about what the issues are. We talk about the staff. She comes to the staff CUSP meetings, and she really, really participates. And next to her is the director of surgery, med-surg services. So all of those people form kind of the leadership of the CUSP team. And I talk about that because as we get to sustainability, it's really important. Infection prevention or quality coordinator can't sustain this by themselves. So, a couple things I'm going to talk about. We're going to review strategies for sustainability, holding the gains. We're going to talk about spreading success unit to unit. And we're going to just talk about the available resources you might have and hopefully answer questions. And then hopefully later on we're going to talk about your facility-specific action plans. So that's important. You know, one of the things I talked about earlier is how are we going to change in local wisdom? And when we talk about local wisdom, it's really engaging the frontline staff. So yesterday, before I left, we had a CUSP meeting on that unit I talked about. And everybody huddles at the nurse's station. And we probably had 30 participants at our CUSP meeting, huddled around the nurse's station, taking a half hour. We had environmental services, we had nutrition there, we had some leaders, we had frontline staff, we had nursing techs. And it's really, really important that you rely on the local wisdom because it is your people on the front line who are going to tell you what's happening. So how do you orchestrate and spread that? And then you always ask the question, what have I learned and how can I keep this going? And that's the real issue that you need to get. So anyways, Gates, although he was a poet, he didn't know he was a party preventionist. But I do think CUSP education is not the filling of a bucket, it's the lighting of a fire. And when you get your frontline teams engaged and excited, and they really want to know what's going on, then you know you have arrived. So quick question, how many people feel that your teams are really, really excited about this? A couple hands. So we do have some work to do, right? Okay. So here we go. All right, this is a CAUTI team. Actually, these aren't, this particular slide is not mine. It's from one of the people on the national faculty, and the great thing is we can share slides. So, wow, doesn't this look great? How many people think they're doing pretty good here? Over 90%, right? They can do better. And everybody's smiling. So here's our team. Here's our first lesson. Wow, we are there. We've got it. We're good. And then what happens? How many people have seen that in their own organization? Do you see that happen? And why do you think that happens? Because we don't care anymore? No, because somebody says, okay, CAUTI's doing well, but I want you to work on C. diff now. This is a new thing. C. diff is the biggest priority right now. And then if you're a nurse manager, well, you've got to work on those calls. And if you're a medical hospital, there's NDNQI data, and pressure ulcers are getting worse as well. And I want you to get this all done so your CAUTI's doing well. Does this sound familiar? But it is the reality of the world. And so how are we going to deal with this? Well, one of the things that happens is that we find that old habits recur. They just do. You know, we do things, we go back. And so the new process has to be integrated into your daily workflow, and it has to be institutionalized. And when we talk about learning from defects later, we'll talk a little bit about first order and second order problem solving. So first order problem solving is what we all do. What do? We say, Susan, you didn't do this right, straighten up. Joe, you didn't put in that catheter, what have you. And we don't really get to what we call that second order problem solving, which is institutionalizing things, making it easier to do the right thing. You know, it's kind of interesting in healthcare, and I've kind of thought about this. How many of us would buy a car that did not have a gas gauge? Would anybody? Okay. But in healthcare, what do? We say, you should know what to do. These are the policies and procedures, and we don't make it easy. So you can say to me, well, Linda, you know how many miles you've driven. You don't really need a gas gauge. You just need to remember how many miles you've driven, and at a certain point, you need to refill the tank. Isn't that what we do with our healthcare workers? So we say, you gotta remember this, you gotta remember that. So we really need to think about getting these things into our daily workflow and institutionalizing them so it's easier to do the right thing than the wrong thing. And we'll talk a little bit about that. And it has to be aligned with the local culture. So what's culture? It's the way we do things, right? What one unit does is not necessarily analogous to another unit. And when I talk about spread, I'll talk a little bit about that. And it has to be easier to do the right thing, right? Because if it's hard to do the right thing, you're not going to do it. And then the most important thing is it needs to be nurtured by periodic measurement and maintenance under the direction of the champion. So think about this slide. That nurse champion is always going to be responsible on A until she leaves. And as a matter of fact, she's finishing her NP, so we got somebody else in training to become that champion, and you have to mentor and foster these champions. And she is always on top of people, and I wish that you could all visit that unit, because I'd like to take that nurse champion, and I'd like to call her, because that's what we really need. So all of you have those people on your units, in your areas, and really foster that local culture, because they're the people who make a difference. So anyways, here we go, delirium sitters, qualities, and unsustainability. And we've got CAUTI, we've got BTE, we've got balls. Oh, I've read about med reconciliation, handoffs, anti-hygiene. So we've got all these things in play. And here's the quality team. So here comes infection prevention and quality. We're ready to roll. We fixed CAUTIs. But handoffs are a problem. Now we fixed handoffs, we got two things, but now CAUTI's falling off. So again, it goes on and on. So planning started when you began the project, and you have the tools, you have the resources, and hopefully this will give you some insight into sustainability. But really what I'm here to do is kind of foster your thoughts. I can't tell you what to do. I don't know your local cultures, but I can tell you some things to think about. And the cost teams and the multidisciplinary rounding and the learning from defects and team checkup tools. And then you have to ask yourself, how do I adapt these cost tools for the long term? How do I keep these going? Because I have so much on my plate. It is unbelievable. And just from my own personal experience in infection prevention and folks in quality and things, there are so many publicly reported measures that we are almost drowning sometimes. And so it's really hard, and we have to figure out how to do sustainability. Just a quick thing about me, I started, our hospital is pretty a large system, but I started in a very small hospital in infection prevention about 20-some years ago, and I was relegated to the basement, and I could hear my ugly head when there was an outbreak or something, then the rest of the time go hide, and I said, oh, if only people would notice us. Well, be careful what you wish for, because now infections are really, the big thing. So some suggestions, though. I'm on a number of coaching calls with some of the states, and all the national faculty take turns, being assigned to states and being on the coaching calls. And here are some of the suggestions that I get when I listen to people. I actually have 3 states now that I'm on coaching calls with. One of the things that really helps are these rounds, rounding on the units. You've heard about this in terms of sustainability, but also connecting the dots. So when you're making those rounds, when you're talking about CAUTIs, a lot of the things are applicable to other infection outcomes. C. difficile, all those types of things. So think about making it comprehensive so people don't think it's one more task, but it's really about the patient. Safety checklist, that's really another good idea. Think about those checklists, making sure, how can I keep my patients safe? Now you've heard about the cost thing. How do I prevent harm? How do I prevent my patient from being harmed? But the question that I heard on one of my coaching calls is that one of the nurses goes around on her unit, takes a staff nurse, and says, how am I going to prevent Lily Greene from falling or getting an infection? And we'll go visit Lily Greene and we'll talk about it. How am I going to prevent this from happening? We are in healthcare very reactive now. We're all into root cause analysis. Why does the patient fall? Why does the patient get a catheter-associated urinary tract infection? Why did this happen? And if we can change our focus and say, how can I prevent my patient, my specific patient, from being harmed? And by harm, it might be an infection, it might be a fall, it might be one of those things. Then we have the frontline team really thinking about that. One of our projects, actually, we had our chief of medicine decided that our CAUTI rates were really high. And he decided that he would round with his residents and take a nurse. And he would go and visit a number of patients and say, tell me why Lily Greene has a catheter. Now, does that seem like something that every nurse could answer? Sometimes they can, sometimes they can't. And oftentimes what we found was, well, I don't know, she has one. So kind of thinking about making it real and hitting home for people. And those are some things we thought. Nurse care, the protocols are a good way to integrate that into the workflow as well, making sure that nurses can have the decision making. And it starts in the emergency department. One of the things that we're finding more and more, and at the national level what we're finding, is the catheters are often inserted in the emergency department because, and I used to work in the ED many years ago, and what did you do? You start an IV, you put in a catheter, And, you know, if somebody looked pretty sick, as many tubes as you could get in, you felt like you were doing a good job. And and one of the things that the Emergency Nurses Association is looking at is, do these patients need a catheter? First of all, and even if they do, let's not say somebody comes in congestive failure and we're going to diurese them in the ED, and then they might need admission. Can that catheter be discontinued before they ever get into a nursing unit? Because sometimes those catheters are lost in space. You know, they put it in the ED, it gets to the nursing unit, and nobody ever asks themselves, well, is this an appropriate use? The other thing that's happening nationally that we're starting to look at is, and all of you know there are CDC guidelines for appropriate insertion, but they're vague because one of the criteria are acute monitoring and urinary monitoring in critically ill patients. Is every ICU patient need to be monitored? Can they use the urinal or the bed? You know, those are the questions that we need to go to the next level. So when I start talking about higher level problem solving, those are some things we'll be thinking about. So what's next? Spreading success. One of the important things is we do need to celebrate successes. And one of the things that we do at our hospital is that we have parties. When you've achieved a certain rate, you know, we hit administration up for pizza or lunch or something like that. And then where do we start? When's it time to spread it to the next unit? You know, because there's such a thing as cross-fertilization. Now, one of the things about spread that I find very interesting, if you've ever heard the book Malcolm Gladwell's Tipping Point, how many have read The Tipping Point? You know that the idea of spread, the idea of taking an idea and getting it to the next place, Malcolm Gladwell says there's three types of people. There's maidens, you know, the technical experts, your infection preventionists. Then there's the salesman, and the salesmen are those people that can really get the idea. You know, they can articulate it, they cut the vision, they see it. And then you got the connectors, and those are the people. Do you ever meet those people that they know everybody? Oh, I tell you, Dr. So-and-so can do this, and there's so-and-so, and they seem to know everybody. And so sometimes it takes, you know, a combination of those types of things. One of the problems, though, I've seen from an administrative perspective, so those of you who are directors or higher level administrators, is you seem to think that it's like a recipe card. So when we had one unit that was struggling to see difficile, and they did just a wonderful job, the CMO came to me and said, well, you just need to spread all their protocols throughout the hospital. Like, as long as we shared the policy, it was going to be done miraculously. So what we need to understand about spread is there's a cultural perspective. It's not just, if we just gave everybody our policies when we have zero cards, somebody has a good policy and we follow it. So kind of think about that. One of the ways when you have a really good idea and you've got a good plan, the first thing you want to do is you want to identify fertile units for spread. Now, what's a fertile unit? Well, it may be sister units that share the staff and population. In my particular example, that surgical unit, that manager is also manager of the surgical ICU. So we've got the same manager. There are staff that sometimes float, you know, from the ICU to the med-surg unit. It's a very fertile unit for spread, and so some of the things that we're doing with our infection prevention initiatives, she's now taken to the surgical ICU. So think about where, with your teams, where might be a sister unit that you can take the ideas that you've already had, the successes that you've already had. Anyone here have kind of spread that to sister units and things like that yet? You have, great. So that's one thing. And the other thing to think about is sometimes you choose units with established safety culture and drive. So I've got something good. This unit has a great nurse manager. They have a lot of long-term staff. They have a lot of dedicated staff. That may be a decision that you want to make. Now you can also identify high yield units. You know, one of the things about being a mess is that it doesn't take much to fix it. You know what I mean? So sometimes people really need these early wins. So you might find an area where CAUTIs are rampant, catheters are rampant, and it's really a good unit. It's just that nobody's focused on that. And why you might choose those units for spread is because you get some early wins. There is nothing more satisfying to people to say, look at your CAUTI rates, look how you are, get everybody moving, and all of a sudden the rates go down, you're really excited. Because the thing about being a good unit is the theory of marginal productivity or diminishing returns sometimes. You know, it's real easy to get lower when you're high, but when you're right below benchmark and not quite at zero, does it take more energy and effort? It sure does. And so those are things you want to think about when you're thinking about this idea of spread. And for fertilized new units in work with administration, so horizontal spread is here. You know, you might go from a like unit to a like unit, or you might do vertical spread. And as I said, we went actually, instead of going from the ICU, which oftentimes is what we did the opposite. We went from the surgical med-surg unit to the ICU. So either one of those ways will, and there's all kinds of things you can do. You know, RN removal policies, CPO alerts, unit team safety rounds, and don't forget the simple things that really make people happy on the front line. That's giving them the resources. When my CNO goes to our infection class, one of the questions that she always asks is, what can I do for you? And one of the things we found in our isolation rooms is that when we went to our electronic healthcare record, which is supposed to save the world, but for those of you who are in the early stages of implementation, it can be horrible. Yeah, someone went, I gotcha. And so to save money, they decided in our ICUs, we have a computer in every room, but now, you know, the wiring would be too expensive, so we got our little computers on wheels that go between the rooms, and now we have isolation rooms, and then everybody's there, well, we don't have time to write down the computer. So you have all those things. So one of the things we went to administration with is we needed computers at least in the private rooms. And you know, when senior leadership's there and they hear the passion of the frontline team about these things, it really does make a difference. So what is the danger of success? Well, the first danger is you take your eye off the ball, and we all do that. There's not one of us who doesn't take our eye off the ball because we have shipping priorities. We're at 100% compliance and no CAUTI, so let's look at something else. And you know, the real question for all of you now is, if you happen to be really good, how do you prevent complacency? How do you prevent getting complacent? And we all get complacent day after day. Well, one of the things we have at our hospital is a monthly board dashboard. And this goes to the quality committee of our board. It goes to our board of directors. It's not rocket science. It doesn't even have grades. It just have numbers. But when I go, as a matter of fact, Thursday, I have to present to our quality committee of the board, and they're going to look at that, and they're going to, and this was 2011 compared to 2012. They're going to say, you know, 4 colon infections, we only had 6 in all of last year. What's going on? You know, so it does stimulate some conversation. It's not a good or bad or right or wrong. So, you know, here's our CAUTIs and our ICUs, those types of things. So those are ways. The other way is keeping the momentum, and I think this is great. You can use a thermometer or you can use a graph. We all know that we need rates, right, for comparison data and all those types of things. But for the nurse on the floor, and you really want her to really get engaged with catheters, how many days has it been since the last infection? That keeps the momentum going. So if you're 0, you can say, I've been 60 days. And we did that with our C. diff. The first time that unit got to 30 days without C. diff, they always had hospital onset cases, 2 to 3 to 5 cases monthly. First time they got to 30 days, they were so ecstatic. Then they got to 60. Then they got to 120. When you get that far, when you get out there, you're like, we've got 1 year without a CAUTI. What happens when you get that first CAUTI? Everybody looks at it. All of a sudden, it's not a common occurrence, and people will think about failure from defects, and they'll start learning them. So a great tool, we posted on a ton of units, so many days without a class, so many days without a CAUTI. We've now been this many days without a CDIF. That one's hard because we keep getting them. But the point is, there are ways to get momentum going by some of the simple tools, and really your frontline staff will own it and they will be excited. Other thing I wanted to let you know about CAUTIs is I have felt they've been the Rodney Dangerfield of the infection prevention world because they don't get a lot of respect, right? Because I got Clad disease, I got surgical site infections, I'm removing total joints because they got infected. So what? They got a urinary tract infection. Who cares? I have to tell you there's a few reasons why you have to care. First of all, for those of you who your ICUs are part of this, we know it's part of the inpatient quality reporting now. It's started to go into value-based purchasing, so it'll be paid for performance in 2017. So our data, I think 2015 and out will go in there, so it's important to administration. But more important, it's more associated with harm than what you think. So let's kind of think about a catheter-associated urinary tract infection. So we treat the patient in our hospital, fluoroquinolones are like water, you know, everybody gets a fluoroquinolone. And then what happens? This patient who got a CAUTI now gets C. difficile, right? So there is a downward effect of CAUTIs, and part of what our job is to make even docs understand that there's more than just a simple UTI. There's patient discomfort. We do know it increases length of stay. There's trauma, immobility. You know, pressure ulcers is big on most everybody's radar screen. And you get that patient out, immobility, venous thrombosis, and even falls. And you know, people go, oh, they have to have a catheter because they'll fall going to the bathroom. But what really happens? They still have that pressure. The little old lady thinks now she has to get out of bed. The phone's connected to the bedside. So what happens? And actually, the data shows that it may actually increase the risk of falls. And then we have all these things about nurses because the nurse at the bedside, is it easier or harder to have a catheter? It's easier, right? And so somehow from a cultural and social adaptive perspective, we have to have them understand why catheters can be very harmful to people. And I even remember my grandma, and I remember I was pregnant at the time, my grandmother had a stroke, and she didn't have a catheter. And I thought, this is terrible. I mean, she's weak on one side, and lugging this grandma, why doesn't she have a catheter? And even as a nurse, I really didn't understand why this is so important. So think about all the things that are related to catheters. So how do we spread success? Well, we need evidence-based efforts, tools, and examples, and there's tons of them. And you know what? I'm by no means an expert. I bet everybody in this room has ideas that I can get from them. We need to be able to pilot on a small scale, measurable leadership support. I have to tell you, there is no substitute for leadership support. I don't mean pat you on the shoulder and say, "Atta, go for it," but being truly engaged as a leader. And it has to be easy to adopt. Now, these are the 4 E's that came from Peter Pronovost and I love this. This is my mantra because it is the continuous circle of engage, educate, execute, and evaluate. And what I love about it is you engage before you educate. How many times do you say, you gotta do it, it's mandatory in service for everybody, and everybody's sitting there and going, this has nothing to do with me. Why do I have to sit here? So part of our job is to engage physicians, to engage frontline staff, to make them understand why this is important. So if I'm talking to a physician, it's not just that Linda Greene got a CAUTI and I'm going to give her some Cipro. It's the downward effect of that CAUTI. Educate. What do we need to know? And give people what they need to know. And the execution is the adaptive phase. How we hardwire that into policies, processes, and procedures will differ place by place. Make sure that you really spend a lot of time, and when you're looking at your sustainability, look at execution, look at what you have in place, and how can you make that. And finally, evaluate. How do we know when we've got there? How do we know things are getting better? And I always think of the 4 E's. I love this, and I use it myself. Now, factors that influence spread, there's a lot of things that are hard. There's the financial issues, because working on costs really takes a lot of time. There's legal and regulatory issues, public opinion, and as we said before, we all have competing priorities, and then finally the just culture. And then we need the local leadership, the knowledge. There's a lot of resistance to change in the safety culture, and then how units really respond to errors. One of the things that I think is really important, and one of the tools that we use all the time, is the idea of storytelling. And I took this from the internet, it's not our patient. But in one of the scenarios I told you about, a lady got caught, big deal, it's a UTI. Well, so it happens that they treated her with chlorphenol, she got doses of Cipro. We're not saying it's causal, the lady got C. difficile. And she required a colon resection. And after a colon resection, she continued to get ill, and she finally died. So, you know, we talk about the Josie King story and all of those types of things, but we all have our own stories in our own organizations. And we don't always think of pride as causing death, but the sequelae associated with it. And so when you tell those little stories, I think it's really, really important. I also tell the Clumsy story that happened in our intensive care unit, and we had a young man who was a trauma, had a ton of things wrong with him, but in the end, he really died because of a line-associated bloodstream infection. So 2 years later, after we had a lot of our initiatives in place, we had a similar patient who, you know, had comparable injuries, had all the risk factors, and walked out of the hospital without a single infection. So be sure to tell those stories. What did we do? Here's a life we potentially saved because we put something in there. And I don't tell you these stories to be like, oh, wow, you know, it's just another thing. But these are the things that strike home, because whenever we put names and faces and people and places to infections, somehow people can relate to that. It's not just a number, it's a name. So do that. So really engage the caring side. You know, everybody came into healthcare really to make a difference for patients. And when what we do, whether we're in quality, infection prevention, or whether we're a director or frontline leader, if we can really make sure that everybody thinks that this is my brother, my father, my mother, my sister, so tell your own stories, really, that's a great way to spread and sustain. So finally, the spread checklist is this: publicize your success, find your high-yield units, and look for more fertile grounds. I bet within your organizations, you've got other units that would love to be working on this. Secure executive support, and that's a tough one. I've been very fortunate in my own organization. My CEO is amazing, and we're a pretty large system, but he believes this. He actually ties some of these outcomes to goal setting and executive reimbursement and things like that. And I know all organizations can't do that, but it is something that he does because he believes that patient outcomes is the responsibility of leadership. Measure the new team. If you are a quality or an infection preventionist, or you're in a role where you're not really providing care, your greatest job is a mentor, a support, really working with the team. Actually, we started something which is hard in my schedule, but you know, you've seen it in the PUS literature, and that's what they call shadowing, only I call it walking my moccasins. So I try to go on one of my units just for half a day and just kind of follow people around. And it's amazing what I find out, and it's also amazing that the things I tell them to do are realistic. And so we have to make those policies and procedures picture is real for people. Because as an IP, what you do, you go on the CDC and you look at the guidelines and you say, pop, 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 you have to do this. And then you realize that the dynamics, the schematics of doing this just aren't reasonable. So you have to figure out how they can do it. Adapt your model to local conditions. I mean, you know, it's more than a recipe card. You got to figure out what's going on. And they're plan, do, study, act. So again, there's the cost toolkit. You have, there's just tons of examples on there. So leverage your coursework, support both sustainability and spread. Make sure it becomes part of the regular workflow, fit within your culture, and make sure that you do that. And spread success requires finding the right team, working with administration, adapting to new conditions, and planning carefully. And I'll leave you because I heard this quote from Dr. Don Berwick, and I'll paraphrase it because I don't have it here. But it really is, and it says, the lives we save can never be known. But what is known is that mothers and fathers will attend graduations and weddings, grandparents will see grandchildren, work will be completed, gardens planted, symphonies heard, all because of the work you do. So keep that in mind. Share that with your team, and I'm just about on time, but if anyone has any questions or will have questions later.
You need us for questions.
All right, anyone have any questions on sustainability or spread? How many people feel